Welcome everyone. We'll go ahead and get started to give our presenters enough time and also so that we can have some time for some Q&A at the end of our session. So just like to say hello and thank everyone for joining our session today. This is the session on statewide telebehavioral health network development. And my name is Whitney Wiggins. I'm a public health analyst with the Health Resources and Services Administration, and I'll be the moderator for today's session. During the session today, you will hear from several speakers about their achievements, challenges, and lessons learned as they responded to legislative initiatives to build a statewide telehealth network that address mental health needs in North Carolina and Virginia. This will be an interactive session. We will have a couple poll questions. So just to let you know, when a poll question pops up on the screen, to participate in the poll question, you will need to be logged into the event portal. And when you're logged in and go to this session in the event portal, on the right side of the session screen, you'll see polls. And that's where you can take the time to answer the poll and submit your answer. We will have a question and answer during this session after each speaker. And then at the end, we'll have some extra time for questions that we may not have been able to address earlier on in the session. If you do have questions, you can type them into the chat section, and that chat button function is on the bottom of your Zoom screen. Looks like a little text box when you're sending a text message. So now I just want to take the time to introduce our speakers for today. We have Dr. Saeed, who's the chairman of the Department of Psychiatry and Behavioral Medicine at the Birdie School of Medicine at East Carolina University. He also serves as the director of the Center for Telepsychiatry at ECU and is the founding executive director of the North Carolina Statewide Telepsychiatry Program, which you'll hear about today in C-STEP. We have Jay Ostrowski, who's the CEO of Behavioral Health Innovation, where he develops and deploys telemental health, telebehavioral health, and telemap programs, and designs HIPAA-secure software applications. We have Dr. Albero, who is a family nurse practitioner and a doctor of nursing practice at the University of Virginia School of Medicine. She's also research program director in the Division of Outreach in the Department of Psychiatry and Neurobehavioral Sciences and directs the Project ECHO initiative at UVA. And then lastly, we also have Derek Hubbard, who's the program director for the Appalachian Mental Health Network based out of University of Virginia's College at Wise. So we're going to start off our first presentation first with a poll question. And our first poll question that we have for you all is, here. But what is your experience with telehealth? So again, if you go to the portal, you should see on the right-hand side a question, and the responses are, what is telehealth? I know about telehealth, but haven't implemented. I'm just starting telehealth. I use telehealth, but not telepsychiatry, or you use telepsychiatry. So if we'll just take 1 minute and see what responses we get. See here. Awesome. So it looks like more than 50% of us are using telehealth, but not telepsychiatry. So this is a perfect learning experience, perfect session. All right. So I think in this session, we will be able to address all of these, those who are just learning what telehealth is, and those who are wanting to learn more about telepsychiatry, and then those who are using telepsychiatry, being able to expand how they're using telepsychiatry and hopefully scale it up. All right, so I'm going to turn our session over to our first presenter, Dr. Saeed from East Carolina University.
Okay. Hello, everyone. I appreciate being invited to be on the panel this afternoon. And can you hear me okay?
Yes, we can hear you. Thank you.
Thank you. So I'm here to talk about the North Carolina Statewide Telepsychiatry program. So I have no conflict potential or will to disclose. And to provide as a backdrop to what I'm going to present on, we know that mental disorders are common. So the most recent data is that roughly 1 in 4 people would have a diagnosable psychiatric disorder in any given year. There's 26.2% to be exact. And when you take that number and multiply with the 2018 census estimate, it gets us 66 million adults. So a lot of people have these disorders. Even when it comes to serious mental illness, that's about 6% or 1 in 17. Still a lot of people, 15.12 million. The reason I'm presenting on the SPMI or severe and persistent mental illness is because I would be talking about the workforce in psychiatry, and SMI or SPMI population is typically the one who would require medication management alongside the psychosocial interventions requiring a specialty care and needing a psychiatrist. So common disorders, so the next question comes up, so if the disorders are as common as they are, what's the workforce look like? So this is the US map by the county. Everything that you're looking at that looks white means there are no psychiatrists there. Ideally speaking, we need 10 psychiatrists per 100,000 population or 1 per 10,000. And that should look like the green color on this map. And you can see that there are not that many counties that meet that requirements, and a lot of counties without any availability of psychiatrists. For us in North Carolina, that's what it looks like. So out of 100 counties that North Carolina has, 29 have no psychiatrist, and more than half of the counties have less than 1 psychiatrist per 10,000 population. Only 13 counties have, and you can see that in the dark green, that how few those counties are. So common disorders, and there is clearly a workforce shortage. This is what boils down for us in North Carolina. 29 out of 100 counties have no psychiatrist. 13 counties have no active behavioral health providers. So this includes everyone, NPs, PAs, psychologists, master trained behavioral health counselors, including behavioral health technicians. So 13% have no active behavioral health provider. And according to federal guidelines, 90 counties, 90, qualify as the health professional shortage area. So what happens when you have disorders as common as these psychiatric disorders? So 1 in 4 people, a diagnosable illness, 1 in 17, a severe mental illness, and there is a workforce shortage. Well, what happens is that many of these patients would start to use emergency department in crisis situation. So in 2013, there's the year that NC STEP, North Carolina Statewide Telepsychiatry program went live. 162,000 people use emergency department for seeking mental health care, typically in a crisis situation. In 2010, roughly 10% of the people who were in an emergency department, they were there for a mental health reason. The average, by the way, for the nation that year was 5%. So North Carolina reached almost double of the number of people who were in the emergency department seeking mental health care. And those were the data that was compiled by North Carolina Hospital Association that year, full year 2012, just before our program went live. And this is the length of a stay for a patient in an emergency department. So someone who went to a state psychiatric facility from an ED, they stayed in that ED for 78 hours average. Someone going to an alcohol drug abuse treatment center, they stayed 33 hours. Even for a community psychiatric unit in a community hospital, it was more than 24 hours. Of course, this is the average, and every hospital ED would tell you that how some of these patients stayed in the ED for not days, but weeks and months. And that was the problem, that patients who are coming to the ED were staying a lot longer when they came in for mental health reason than they were coming in for any other medical condition. And what would happen is that when these patients would show up in an emergency department, part of the delay was because they needed inpatient treatment and a bed was not available. And part of the reason was because many of these hospital EDs did not have access to a psychiatrist who could make an assessment and make some recommendation about the disposition. And that was the problem that we suggested, that using telepsychiatry can be helpful there. How the program started was that because of these long length of a stay in the emergency department, about a dozen or so entities approached the Department of Health and Human Services seeking help. These entities were organizations like North Carolina Hospital Association, now Healthcare Association, North Carolina Medical Society, College of Emergency Physicians, Psychiatric Associations, and several others, and saying that we need help solving this problem because when the patient is there for a mental health reason, they were staying for a long length of time, basically choking the capacity for those emergency department to care for other patients who were coming in for other all kind of emergencies. And that's where we suggested that, yes, telepsychiatry could be helpful. A group of us from East Carolina University were invited as a content expert to figure out a solution to that problem. We did not want that solution to be all ECU, East Carolina University centric. We approached that as a problem for the state and convened a group of people representing those organizations that I mentioned, several large healthcare systems in North Carolina, 4 universities with medical schools at the time, like Duke, North Carolina, Chapel Hill, ECU, Wake Forest University, several people from Department of Health and Human Services, as well as community representatives for managed care organizations, and several others. And what you're looking at on this slide is just gives you a glimpse of that who these people were. And we call ourselves North Carolina Telepsychiatry Work Group, and submitted a recommendation in the form of a report to the Department of Health and Human Services that was presented to basically the legislature in North Carolina. That resulted in establishment of a program under the General Statutes 143B-139-4B, in 2013. So we were written in the budget bill of North Carolina that year, and then we were recodified in 2018 for expanding the scope, and I'll come back to that later. And this is just a glimpse of the law that was written that in this statute, it was decided that East Carolina University Center for Telepsychiatry will be home for a statewide program taking care of patients who are showing up in the emergency department anywhere in North Carolina in a crisis mode if that hospital did not have access to psychiatrists. So just a couple of pictures from there. So governor came to East Carolina University and made the announcement of funding of the program. So there's the top picture, and on the bottom, Secretary of Health and Human Services, Dr. Aldona Wash, with the governor, who were making an announcement for a start of this program. The vision of the program was simple and straightforward. We were not there to compete with anyone. We were there basically to help emergency departments that did not have access to a psychiatrist. So very broad vision, saying if there is a patient in an ED that needs to be seen by a psychiatrist and hospital does not have access to a psychiatrist, we would step in and take care of that patient. The very first challenge we encountered was that since by definition we were talking about a program that would be stretched across the state, we knew that we would be encountering several different electronic health records. So how would our psychiatrists scattered all over the state see this patient in these multiple EMRs? Just to give you an example, the year that we went live, 50% of the hospitals in the state use Epic. 70% of the hospital use one of the three, Epic, Cerner, or Meditech. And then after that, the sky was the limit, and the number went up to 20 to 30 different EMRs. Health information exchange was not available at the time, although in the statutes it was a requirement. So the very first challenge we took on was to come up with a web portal pretty quickly where we could schedule patient, schedule not as an outpatient because these are ED visits, but get those patients on the roster to be seen by the psychiatrist, and then providing a way for our psychiatrists to exchange clinical information without having to learn all these different EMRs. Then collecting all of the encounter data that would support not just the clinical needs, but also the billing and other purposes. And we reported on this. So there are two scientific papers that we published on development of this web portal. One was published in Psychiatric Services, and the other one was in Psych Quarterly in 2018. So this is the current footprint of our program. Everything that you are seeing in purple with a red dot. A red dot is a hospital emergency department. So we are live there, meaning if there's a patient in that ED at this time, that patient is being seen by NC STEP. And then the lighter color counties are the ones that do not have a hospital in that county, and we are serving that county by that adjacent dark purple color county through NC STEP. And then the blue diamonds that you're looking at is when we expanded the scope to outpatient settings and started providing care in the community-based settings. And that started in 2018. So you can see that this is truly a statewide program, stretches from mountains to the coast, from Murphy to Manteo. To date, we have 41 hospitals in the network, 40 of which are currently live. The last one is going live sometime this month. Since inception, we have seen over 45,000 patient assessments. We have overturned 6,688 IVCs, which directly correlates with basically preventing unnecessary hospitalization And that in itself is a saving to the state in excess of $36 million, which roughly equates to, for every dollar invested in the program, we have saved 3. We have 6 clinical provider hubs with 42 consultant providers. They are all over the state. Our administrative costs are below industry standard. And even to date, we keep close tabs on our payer mix, and it's exactly a third of our patients who do not have any insurance. So a third of our patients do not pay us anything for their service, and that's the one that's supported through the state legislation through the $2 million per year in recurring dollars. And in 2018, we asked to expand the scope of the program from emergency department to community-based settings, which is a collaborative care or integrated care approach. And we currently have 13 community-based sites that have gone live since 2018, when we were recodified in the state statutes. And in that program, we have seen over 6,000 patients to date. This just gives you a glimpse that how the program is utilized. Busy slide, and my main point to take home from this slide is that we work some very large hospital where we may have seen as many as 4,000 patients, and we serve some very small hospital EDs where we have seen only a handful, typically about a couple dozen patients. Our internal benchmark to take care of the patient from the time the patient is referred to us, NC STEP, until a report of consult is in patient's chart, and we call it a consult elapsed time, and that currently stands at 3 hours and 50 minutes. So under 4 hours from the time the patient is referred to us, a psychiatrist would have seen that patient, and the consult report is already in the patient's chart. These are the data on overturned IVCs, and we have closely drilled that down to, does it really mean preventing unnecessary hospitalization? And that is the paper which is currently under review, and we'll be publishing that hopefully soon. But we have documented that these overturned IVCs before the inception of this program, they were all getting transferred to a psychiatric facility where they were hospitalized. And because of these overturned IVCs, we have been able to take care of these patients in community-based settings. This is our payer mix that you can see that it's a program where a third of the patient basically do not pay us anything. They are uninsured. And majority of these patients who we are serving are Medicaid, Medicare, or underinsured. Our commercial payer mix typically hovers around 15% of that mark. And in 2018, we asked to expand the scope of our program to provide a collaborative care approach or integrated care approach. And that's where we build relationship with already established primary care sites, rural health clinic, federally qualified health centers, and similar programs. And that's a demonstration program that's up and running, has been for 2 years, and we hope to expand that to hopefully somewhere around 25 to 30 within the next 3 years. We have at this time about 7 scientific papers, 8 under review, that we have reported on the findings from our programs. And thank you, Metric, for giving us the 2020 Breaking Barriers Award, which was last year. So in conclusion, what I summarize here is that telehealth is certainly a viable and reasonable option for providing mental health care to those who are currently underserved or who lack access to services. The current technology is more than adequate for most users and continues to advance. There are many documented benefits of using telehealth. And NC STEP that launched in 2013, we have seen over 45,000 patients and prevented over 6,000 unnecessary hospitalization, thus saving the state in excess of $34 million. Telehealth can also help with the surge in mental health and substance use disorder patient that's already occurring in the aftermath of the pandemic. And NC-STEP team-based approach to care has developed a scalable model that can be implemented at one site or statewide. And currently there are two bills, both in the House and Senate in North Carolina, basically sponsoring the expansion of NC-STEP to those sites. Our funders include basically the North Carolina legislature, Department of Health and Human Services in North Carolina that provides us $2 million in recurring funding a year. We are partially funded by HRSA as well as the Duke Endowment Foundation. And I'll stop at this point and stop sharing my screen. Thank you.
Thank you, Dr. Saeed. We do have a couple of questions from your presentation, and so I will read those and let you respond, and then we'll go on to the next presentation, but there's more questions that come in at the end. We'll get to those. And so the first question was, are there certified peers working within this model?
I'm sorry, I can barely hear you.
Are there certified peers working within this model?
Not in the model that I just presented. We just recently got another HRSA grant to expand NC-STEP in community-based sites. We are providing care coordination and we'll be bringing certified peer counselors to that. But in the ED program, we do not.
Okay, great. And then another question was, can you elaborate on the referral process for this model?
Referral process?
Yes, the referral process.
So referral process, this is basically a referral that would come from the emergency physician. So the patient in the ED, an emergency physician would make the determination whether a psychiatric consult is needed. So typically these are the patient with complexity that's enough for ED physician to seek such consult. Some of the straightforward cases don't get referred to us. From the community-based program, the referral process is threefold. Every patient who's coming in that integrated approach would get screened up front. So this is usually a PHQ-9 or anxiety disorder 7 scale. So if their score is high on this, primary care would assess that patient, and then the primary care physician would make the determination whether he or she would need a consultation. So that's number one. The second one would be that our psychiatrists, when they have done the consult and the primary care physician has implemented that, if the treatment response remains suboptimal after so many weeks, the primary care may refer the patient again, saying, I've tried everything that was recommended, and still the outcome remains suboptimal, and we may actually see that patient again. And the third one is pretty much when the patient comes in, sees the behavioral health counselor and determined to have serious mental illness. And at that point, both primary care and the behavioral health manager makes the determination that this patient can go straight forward to the psychiatrist for that.
Thank you. We had another question about links to the published papers, but just for reference on that, the slide deck is available in the portal under the resources tab for this and documents tab for this session. And it has all the published papers that Dr. Saeed showed on his screen. So that's where you can see those published papers and then find those published.
Thank you. And my contact information, email is available there as well. So if anyone has difficulty locating from that information, I'm happy to receive an email.
Great. I don't see any other questions that have come in for this presentation right now. So we're going to go ahead and move to our next speakers and presentation from Appalachian Telemental Health Network. And before we start that presentation, we do have another opportunity for y'all to participate, and we have a poll question for you. And just a reminder that you can participate in the poll questions by logging into the portal for this session. On the right-hand side, you'll see polls, and the question will be listed there, and you can type in your answer. So this question is, what are some barriers you experience with telehealth? This is open-ended. We'll see your answers. All right. The question again is, what is some barriers you experience with telehealth? Sorry. Okay, so I will ask Jason if you'll share your screen, we can see what some of those answers are. So we have access and devices, especially when it comes to substance use disorder, sustainability, broadband issues, technology, HIPAA-based platforms. All right. And so in our next presentation, I believe we'll talk about some of this, and at the end as well, we will, if there's other questions about when it comes to these barriers and these programs, we'll ask our speakers to touch on them. Right. I'd now like to turn the presentation over to our next speaker, Derek Hubbard.
Thanks, Dr. Saeed, for the great discussion that you just had. My name is Derek Hubbard. I'm with the Appalachian Telemental Health Network. The ATMHN, as we call it, was created as a program that was funded by the General Assembly of Virginia in order to establish a behavioral mental health network to the underserved counties of Virginia via telehealth. So the Appalachian Regional Commission designates certain parts of states that have been designated as Appalachian. So for Virginia, everything that's in the far southwest corner is considered Appalachian. So that's where we have to focus our patients' referrals to come from. But we recruit any type of mental health provider from all over the state. So we can recruit social workers, counselors, psychologists, psychiatric nurse practitioners, PAs, so on and so forth. So that's kind of where to bridge that gap between those patients in Appalachia and also the providers all over the state. So the program has envisioned a consortium of hospitals, clinics, even education institutions that work together for a region-wide telemental health network. So we face the similar issues that they have in North Carolina as far as being rural with access to care, broadband issues. We're no strangers to that as well in far southwest Virginia. So with the increased access to providers that our network has provided, our main goal is to reduce the barriers of time, distance, and provider scarcity. So that's one of the main things that we really try to focus on is access to care. So one of the other things I want to touch on, the crucial component to connecting any referred patients with a rendering provider that's all over the state was the development implementation of a software platform that we share with our mental health providers to use. It's a HIPAA-compliant, Zoom-based, low-cost telehealth platform provided by Adaptive Telehealth, and it's increases our access to care. We can collect data on usage, We also, engage key stakeholders to make sure that we're sustainable beyond the network period, the funding period that the state has provided. So we definitely have to be aware of all of the access issues. So definitely when it comes to, low bandwidth that people have, that's one of the things that's a strength of our platform is using low network connectivity. One of the things that also our program not only encompasses a telehealth network of providers that people can choose from to get services either from in the doctor's office, they can coordinate that with them, they can do it from home, see some of our marketing materials to get access to the telehealth platform and see providers that accept, all the types of insurances that we have. But one of the other things, this entire initiative that the state wanted us to also focus on is pull in other partners that are doing similar missions that we can kind of work together to better all of our programs. So, our additional partners are vital to the success of our program. One of the ones I'd like to mention is the Virginia Telehealth Network, which they work in conjunction with our program to integrate existing and future telehealth initiatives. So our program is strictly mental health and behavioral health through telehealth. So we do have other partners and stuff that do other telehealth initiatives that we work with and try to connect, those people with the people that we already work with. So another main issue that we found too in Virginia is, provider scarcity. So there's lack of fully licensed mental health providers, either needing supervision hours or, may need to expand their in-office offerings to telehealth offerings. So it's a multitude of issues that we think that we've been able to close that gap with. So we're, diving deeper into this program and looking to expand outside of Virginia into the other Appalachian regions to see how we can, remove those geography barriers of state, because down in far Southwest Virginia, where we border North Carolina, Tennessee, Kentucky, and West Virginia, all within an hour drive, we have to be creative to see how we can expand and help those other groups that are facing some of the same issues that we're having. I also want to mention the University of Virginia's Carrie Nancy Rubin Center for Telehealth and also the Telehealth Village at University of Virginia Medical Center. They are also partners in this program that develop and produce new training modules for telehealth competency and update content for existing training models. I encourage you to visit Telehealth Village. They have a lot of continuing education unit worthy material that you can purchase to learn more about telehealth or some of the realms of telehealth. We actually have a module that's almost complete since we are a predominantly Appalachian organization that has most of our patients come from Appalachia. Some of our providers may not be familiar with the Appalachian culture. So we have worked together with the UVA-WISE's Center for Appalachian Studies and also with the Carrie Nancy Rubin Center for Telehealth to offer some Appalachian cultural competency module that kind of gives you a little glimpse about some of the cultural differences with people of Appalachia versus, everyone else. That's really beneficial, especially for telehealth. And then one of our final partners is Project ECHO that Kim Albero is going to be speaking about later. So I won't take her thunder to talk about Project ECHO, but I will pass the baton over to Jay Ostrowski to dive deeper into the partnership and stuff that we have with the Appalachian Telemental Health Network. And thank you all for allowing me to speak with you all today.
Thanks, Derek. As a clinician myself, I've learned a lot about Appalachian culture. I've worked in Virginia and North Carolina for many years, but actually talking with people from Appalachia about the differences has actually made a difference in my clinical work because there are some nuances that you can really have a disconnection with people if you're not aware of that. So I would encourage you to check that out, the Telehealth Village. So this is a little slide about me and some of what I do. On this project, I've been the person in charge of the software, developing and designing the software, implementing that, a technical team, and then also training providers. We did a lot of training, as I'll talk about here in a moment. The challenges that we were trying to address right up front were, we've worked as a consultant for Matrix and other organizations. We found that, providers come with very different needs, very different workflows. A lot of times they maybe don't know what they want or know what's possible. Most of them want to replicate their current workflows, and we found that there's some challenges with that. But in the area, we just had this lack of providers for mental health and psychiatry. They had nowhere to refer to. So people living in the mountains, in the mountain areas, have to drive, sometimes a few hours to get a provider. And we know that's just not going to be, tenable. Also, just a low bandwidth or no bandwidth, and trying to help them work out those issues. And we're not a lot of organizations working together outside of their kind of silos or organizationally. So we wanted to kind of connect those to help them refer to each other to just expand access to care. So our solution to these problems was, again, to try to work with the challenges that each organization had. A lot of times these small practices are resource strapped, right? They don't have the technical knowledge. Maybe they don't even have an IT staff or someone that maybe does IT but doesn't have any knowledge or expertise in telehealth at all. And so they're looking for, what do we select? And then onboarding these solutions can be very expensive. So we wanted to overcome the technical challenges as fast as we could. We wanted to overcome the financial challenges of startup. And then, of course, just the will. It's like when you start looking at how to start a system, it can be kind of overwhelming. So we wanted to basically come alongside these providers and the provider groups and say, look, we're going to provide everything you need to get started. So here's software that's HIPAA-secure. It has over 100 features that you guys can pick the workflows you want, and we stand those up with your branding on them because we just want you to do the services. And then we would do the technical assistance of kind of hand-holding them through the process and training them on what's possible and what they can and cannot do, and then setting up their current systems online. And then, as they go forward, training them on HIPAA security, because a lot of them didn't have that technical knowledge. And then kind of helping them know what they don't know, right? So since they're already shorthanded and time strapped, we try to do that in really consolidated ways. And we were able to onboard, I think, up to 300 providers at this point across the state. So part of the vision was to create like an ecosystem. Not just a telehealth, software, but here's kind of the whole package. So we wanted to do the online office, we called it, because sometimes some people didn't have electronic records. We provided that for them, or an API and data connectivity with their own EHR. So not have a one size fits all approach, but really kind of go and meet where they are and help them with the solution where they are. So the software is able to do that with lots of different features. So some people want to do maybe PHQ-9 workflows up front, or have an immediate feedback from the client right after a video session, or be able to pay online. And so lots of those challenges that if they weren't already working with their own EHR with that, we would provide those services for them. And some people are doing kind of a hybrid spectrum of different services. Some they're handling in-house, and some they're using in this software. And then they're able to download the records or refer their records or send the records in a HIPAA-secure manner through the referral systems. So the technology is one layer. And then part of that, we working with the feedback we got was that some people wanted to have an online directory where consumers could just find a clinician and set their own appointments and have that workflow. Some clinical staff said, we don't want that workflow. We don't want to be public. We want to screen patients better than that or differently. So we would create an internal directory that was a clinician to clinician directory where they can search by different characteristics and refer internally without being publicly exposed and having kind of spam clients. And we'll show you some screenshots of that in a moment. And then I mentioned before the technical support. So here's how to use the software. We trained them on that. We would do a little troubleshooting at their local level, integration with their own softwares, workflow kind of design and support with that. And so we had basically two-tier support teams. We have a frontline support person that's full-time, and then a second-tier technical team that would come in and kind of a triage and like a hit team, if you will, a SWAT team to help solve problems quickly. And then we support them throughout. So after the startup, if they have new ideas or new things they want to do, or new staff, we would train them and support them. And then, of course, the telementoring ECHO program is ongoing as well. And Dr. Barrow will be talking about that as well. So this kind of, not just the training initially on how to do telebehavioral health, which we did, and the HIPAA security, but then, as they go ongoing, they have access to staff to help get that training. And then we did recruitment, and Derek's team was a big part of that, is recruiting the providers. So if you open the state network, they don't just come. You actually have to go and talk them into it quite a lot, and that's one of the challenges we'll talk about. The provider, all of this, to put perspective on this, all of this was before the pandemic. We started this the year before the pandemic, and so we were grateful to have things up and running when COVID hit. So provider adoption is not just telling them about it, but helping them actually get their hearts and minds engaged and help them understand that this is not a replacement for in-person therapy. It's helping people get access that couldn't normally get care. And then, of course, the other part of the system, if you will, the ecosystem, what makes that work is recruiting the providers to refer to the system. So I've been a part of a lot of different startups and different programs where they didn't think about the referrals enough. So we emphasize that pretty well up front. So a lot of other systems will create a provider network where you have a lot of providers trained and ready to go and then no clients. So we talked about quite a lot this balance that you need of equal patients and providers so that you have the supply and demand and the ecosystem working quite well. And then another part of the program that Derek and his team set up was the client recruitment, also just direct recruitment, direct awareness programs to that whole area that they now have care online. And they even did billboards and TV spots and different outreaches and work with other influencers in the area for that. So the idea was this kind of whole package ecosystem that's worked quite well. So one of the barriers that we initially found was the HIPAA security. The providers didn't know what to use or how much HIPAA influences what they do. A lot of us as clinicians got HIPAA training maybe in the 90s and not a lot of training afterwards, even though we're supposed to have like an annual update. So we had to kind of re-educate people on here's, access controls and monitoring and security procedures. And here's the administrative part, the technical part, and the physical part, because if you see a software that says HIPAA compliant, all you know is that they have a marketing icon that says HIPAA compliant, because technology is not enough. Encryption and a BAA are not enough. So we would educate them on here's the policies, procedures that you need to put in place to be completely secure. So we did some of that education and took care of obviously the technology part of that for them, but would educate them on that. So every organization, as we mentioned, has a little bit different way they like to do things. The big joke in telehealth consulting is if you've seen one telehealth program, you've seen one telehealth program. So with that in mind, a lot of people say, well, how do you scale a system? So the way we scaled one software is to make it very, very flexible. And so we used adaptive telehealth to make it where each organization kind of have their own flavor, their own style within the same kind of umbrella of the software. So some have their own self-registration that fits their own protocols and their own policies and workflows. So every organization actually has that individual workflow that fits their needs with their own data points labeled their own ways. And then on the back end, we kind of sync it into one database where we can aggregate and pull the statistics for the state. And then some people like the public directory, some people like the private directory, some people want both. So the providers are kind of able to get what they want. And so far we've had a really good success rate with adoption of the people that are engaged. Also, some people want treatment teams, and a lot of softwares aren't made with the treatment team approach. There'll be like individual licenses. So what we did was we made those individual licenses, but we also made a treatment team where they're able to help each other's clients and access appropriately to records with the file sharing and the internal messaging and documentation of basically an online office. And then the third thing that we found that was really big for each one of those is the branding. They want to have their logo on it. They want it to look like it's theirs and kind of take more ownership of it. So we were able to, provide them with that branding to kind of put their face up front, something that would decrease their costs because they needed less tech resources because of this program. So this is just a screenshot of the homepage with some annotation on it, where we are offering them to, once they come here, they can see that they can do quite a lot. And this homepage is a little tricky because it's made for 3 different audiences. It's made for the clinician that wants to get involved. It's made for the referral source that wants to refer to the program. And it's made for the client that might stumble upon this and go, I need help. And so we have those 3 different groups. And then some people might just go, what in the world is this? They're maybe part of the media, and we needed to kind of educate them on telebehavioral health. In fact, we found a lot of providers were kind of interested in beginning. They didn't really need to do anything different because they were full. A lot of them are full already. So we had to go outside the Appalachian region to the rest of Virginia. So to equalize basically the availability of users. So there's providers in one side of the state that have openings, and then there's clients in the other that can't get help. And so we're just matching these people through the software. And once they understood the telebehavioral health is, it's legal, it's ethical, it's funded by the state, and it's reimbursed by Medicaid, Medicare, and a lot of the third-party insurances. Once they realized that they can do a business from this, they really got on board. Of course, COVID actually turned, put that on steroids, and we had a lot more and strong and consistent adoption after that point. And even though it's waning, COVID is waning in some parts, we're still seeing strong and even increasing adoption by our providers. So we're happy that the system is working consistently, and they're happy with that. But we know that this is a kind of an evolution process over time. As they have different needs, we're trying to adapt and respond to those, and I'll come back to that. So when I talked about many options, first of course was the HIPAA security, but we found that a lot of providers have different types of needs, and every organization is very different. So some had more administration needs, like they needed management to see and collect stats on things and have reports, or maybe they had a front office staff or billing staff that needed to be involved and have access to certain portions. And certain very specific workflows that fit their financial models, and the way they practice is very different. Some of them really wanted different customizations that would make their workflow easier. We didn't want the software to get in the way, so we would go ahead and make some of these small adjustments to make them happier. And then we needed the compatibility of a website access, or maybe a mobile phone access, or iPad access, Android, Apple. So we wanted to make it kind of ubiquitous. And then some had maybe a university that had, H.323 video, and they needed to connect with that, or a cart even. So we would connect someone's mobile phone with a cart. So kind of made it really accessible to remove basically all barriers, and especially the API with different medical records. We wanted to make sure that that was quite easy. So we worked with the technical staff to do that as well. A lot of companies wanted a lot of different features that were not consistent with each other. So some wanted referral systems, some wanted approval systems. Informed consent with signatures were very popular. Some wanted a library of content to distribute to their clients as they went. Scheduling was another popular one. Some want provider-only scheduling and admin scheduling, and some wanted client direct scheduling. So they would make little openings and show their open office hours, and the client would go in there and select their own after they logged in. So we had a lot of kind of neat innovations. We've learned a lot about what different populations want, and what we end up at the end is one size still doesn't fit all. And we also had a lot of different roles. So of course there's a provider role and the patient role, but then there's a referral source role, biller role, supervisor role, executive kind of higher level Derek role, where they can see high level what's going on and aggregate data. So that was also something quite useful. So this is just a screenshot, a sample of fake data. So we're not giving away anything here. And this orange is what your eye is drawn to, is just what happens if there's a referral in the system. You log in, you see your calendar right away, and of what's in person versus online schedule. And then you can see, oh, you have referrals in the network, and you click on that and just accept, and all the data is imported with no extra typing. So I joke that I'm allergic to typing. And people like that we auto import a lot of data so that there's not a lot of replication of tasks. So the The dashboard's quite easy. They can see their client load and click, and everything's kind of searchable, sortable. We have it in English and Spanish for those that need it in the Spanish language. It's all just, I click the flag and it changes the whole language for those that have different language issues. We also had the provider directory, and this is a one sample of it. On the right side, you can see you can filter by, if you click the filter button, it'll show insurances and different types of specialties so that they can pick the provider that fit that patient and refer directly to them. That could be done through the system as a message or as a fax. We would set up fax lines, so HIPAA-secure fax lines within there to make that work, or connect to their current fax line if that's what they preferred. Then we also made some, some simple kind of graphics to show kind of how easy the system was to use. So kind of a 3-step method of, they go here, select, sign up, schedule, and then meet. And it really is that simple. So we found that that's really been helpful with user adoption. And then, of course, referral workflow is a little more complex, but we made kind of these reference sheets to help them understand that. Some organizations wanted more of a triage system, so people can kind of self-select what they need and get either kind of a library of resources, or get a workbook, clinical workbook, or live video or live chat even. So again, every organization wants different workflows. We would do that starting with maybe a DAST or a PHQ-9 to go through these workflows. Some of the challenges, and I know we're going to talk about this more on the question and answer part. Some of the challenges we face were just helping the provider groups understand what they want, and understand, kind of educate them on the options, and then help them design the workflows. We started by trying to design them as close to what they use now, so that there's not a lot of change, because change is, something that is stressful for everybody, right? But from that, we found, adoption was pretty simple once we educated them on what telebehavioral health protocols are appropriate, help them use best practices. So slight adjustments in workflow just for the telebehavioral health part, but we embedded in that to help them. So we'll come back to more of that in our question and answer, but let me turn it over to Dr. Albero to make sure we have time. Oh, real quick, our next step is we're creating an incentive plan and creating like a credit system within to help people get free supervision and free counseling over time. So that's what's coming up in this next year.
Okay, so just to build off of this and give you some examples of how we're using Project Echo in this setting. Some background on the Appalachian Telemental Health Initiative is that the funding for this came out of legislation that was put forth by Senator Creed Deeds from District 25 in Virginia. He was attacked by his son, who then committed suicide, and his son was known to have a mental health disorder and was having a lot of issues and concerns that were raised by friends and family, and didn't have access to the kind of mental health care that he needed. And so Senator Deeds took on this this program, this project, or he proposed legislation that would allow for funding to be built into the state budget. And from that came the Appalachian Telemental Health Initiative and additional funding for other Project Echo programs in the state. So I'm going to go ahead and talk a little bit about the Project Echo program so we have time for questions. Project Echo, in case those of you are not familiar, it stands for Extension of Community Healthcare Outcomes. In this setting, we are using the Project Echo model to disseminate best practices and to bring some of the content that is included in both the peer collaboration and the Appalachian Telemental Health Network to providers who can utilize it in their own practice. So the idea behind Project Echo is that everyone has something to learn and everyone has something to share. We invite community providers to join our sessions that allow that allow for sharing of cases and discussion, along with some brief didactic presentations from experts in the community. So we have at UVA, which is where our project is centered, we have psychiatrists and counselors, we have social workers and some other community health outreach folks who are able to share not only the resources from the University of Virginia, but also throughout the state. And the connection between the providers also allows for providers in similar geographic locations to share local resources and information that's specific to that part of the state. With the setup, we use Zoom to be able to connect everyone. And what ends up happening is that although this is intended to expand the capacity of primary care providers in Appalachia, we have people join from all over the state. So this is just a brief shot here of where we have had folks, primary care providers and entire teams of behavioral health providers join. And the arrows that you'll see here have points on each end, because in addition to the information and the best practices information that we're disseminating, we're also getting a lot of information back from folks. We're learning about their needs and any new and additional resources, practices that are specific to areas of the state that we might not be aware of in Charlottesville, Virginia, but that definitely impact patients throughout the state. And through telepsychiatry and the use of the interactive and telemedicine platforms that we're able to use, any provider in the state can see a patient in any corner of the state. So it really is important that we reach out beyond just the southwest corner of Virginia, but also to help providers throughout the state to know about the resources available, and also to connect and be able to participate as providers to see those patients that are located in the Southwest region. So the purpose of this is really to expand the primary care provider's capacity to manage behavioral health conditions. In the setting of COVID, we've really used the platform to disseminate best practices and changes to the clinical protocols and any updates in pharmacotherapy that have gone on. And this also is a great way to build a professional network, particularly for those providers who are the only provider in hundreds of miles around. And it really allows for a building of both the professional network and a bit of a social network to be able to discuss with one another and share with one another, and then to offer some input on case collaboration and case consultation. So the model is technically called telementoring, because we're not doing a true consult, we're not doing a true takeover of care. Although patients can certainly be referred following Project Echo sessions, but the idea is for there to be a good exchange of information with every one of these sessions that is applicable to all of the participants. Additionally, there's just an expansion of the thinking of, and then familiarity and comfort with managing more complex cases for primary care providers who are increasingly being asked to do more and more in the behavioral health realm without necessarily having a behavioral health specialist on staff. So as part of the Appalachian Telemental Health Initiative, we have worked on topics that include behavioral health, opioid use disorder, neonatal abstinence syndrome, a lot of different conditions that span the lifespan, as well as extend just the comfort level of those primary care providers in caring for their complex patients. I'll go ahead and stop share, and we can go to questions if that's what's next.
Yes, thank you all for talking about your program in Virginia. So we don't have any specific questions from the presentation that we just had, but I'd like to ask an overall question, and it was covered, some of the challenges were covered in the presentation from Virginia. So I'd like to ask Dr. Saeed if he would talk about his biggest challenge and how ECU and North Carolina are continuing to overcome and address the challenge with your program.
So we had several. One I already mentioned is dealing with what we call the Tower of Babel problem. So too many EMRs, how to deal with that. So we tackled that by developing a web portal. The other challenge was credentialing. So when you're providing psychiatry services in emergency department, you have to be credentialed in that emergency department. So at the high end, we served as many as 76 hospitals. So imagine credentialing 47 providers in 60 some hospitals, which on an average would take as long as 3 months just to complete credentialing. And of course the provider shortage. So building a network. So we are not using docs who are just within ECU. We are using a network that we developed for the program statewide. But given that a third of our patients don't have any payment to make to us, the rates that we pay are barely over Medicaid rate. So it was really hard to bring people on who would accept the payment that we can provide, given the limited sources of funding.
Thank you. Thank you for sharing that. And I know, Jay, you touched on a couple of challenges, but was there any other challenge that you would like to expand on?
Yeah, I think one of the big ones that I know Derek might want to comment on as well is some provider groups are kind of siloed, and they don't want to be a part of a program that includes competitors. And so I think that's going to be overcome as we get more and more people on the network, and they can see that it's not competitive, it's collaborative, and we're sharing resources and sharing referrals. So there's enough business in the state for everybody, and I think that's just a matter of getting the right people to understand what we're doing and sit at the table and talk through whatever challenges might be there, and to overcome them. And sometimes it might be data, sometimes it might be politics, sometimes it's fiefdom. But we've worked very hard at doing that and collaborating together. The other kind of exciting thing is getting universities involved in their training programs to provide, basically when you're going through counseling training or social work or psychology training and residency, you have to see people as part of your training. And we have a lot of people that could benefit from those kind of free or very low cost services. That's in the training program. And then postgraduate, we have to go through a few years of postgraduate supervised work. And that's our next phase, is including those people into kind of free and very low cost clients to get their hours, their training hours involved. So that's kind of a win-win, because we get more people served, and then those with needing hours can get their hours as well. And the supervision can all happen within that, and actually reduce the cost of training and onboarding of these new providers, while at the same time providing more access to care for people that have low or no income. Derek, did you want to add more to it?
No, that's exactly the direction I was going to go. Jay was talking about how we can kind of kill two birds with one stone, as you mentioned, with getting those people that need their hours to be fully licensed and giving those visits away to the uninsured and underinsured. Because even though Virginia did expand the Medicaid a few years ago, there's still a large collection of uninsured and underinsured people that may help. And another thing that we've also found in our experience with this over the last couple of years is we've tried not to market directly to people, as far as saying, you need help, you need this, but focus it more on more of a third person to say, hey, do you or someone that you know need help, and talk with somebody. Because we feel that if you go at somebody directly, we feel like it's not been as good a response as saying, or somebody that you know, friend, family member, somebody like that. So, we've had some success with that, but we definitely want to figure out a way to integrate this into people's lives and make it kind of their go-to program, because, I've had this experience, over the last year, is telehealth is really the wave of the future, and it's gaining momentum even more. And I'm glad that we're right in the middle of it and working to help people, because I don't think it's going anywhere anytime soon.
And Derek, do you want to talk about other states? Because the name of the Appalachian program itself was not Virginia Telehealth Network, it was Appalachian Telehealth Network.
Yeah. Virginia signed on as kind of the pilot program. There was some, very high level meetings and talking about how could they do something for the Appalachian region, because, we're all so close culturally, geographically we're close. So we've also found that, there's a lot of issues, people that come from West Virginia into Virginia for services, if they're not, physically residing in Virginia, they technically can't use the system, so there's a lot of barriers, with those invisible state borders, that we're trying to close that gap and expand definitely immediately into Central Appalachia, like I mentioned, West Virginia, Kentucky, Tennessee, North Carolina, and then with the hopes of expanding all through Appalachia and nationally, just because, it's such a unique platform, and the support and stuff that we've got from Adaptive, it's been incredible. And, there's only one way to go, and it's up, and that's where we're trying to keep moving forward.
I think you dropped the mic. Walked off.
It was a good conclusion there, but thank you all for sharing about your programs that you're doing in the states that you're helping, and how you've been able to work statewide to address mental health needs using telebehavioral health and telepsychiatry. Thank you all for coming to participate in this session. There is contact information for our speakers and their slides, as well as on the portal. We had several people who are doing telehealth, but maybe not telepsychiatry. So I encourage y'all to reach out to them as you're wanting to learn more about telepsychiatry and meeting mental health needs using telehealth in this season. I believe this is the last session for the day. There are some poster sessions occurring, so if you want to go back to the portal and check out those posters. Otherwise, we look forward to seeing you all at the summit tomorrow morning, 9 o'clock a.m. sharp. So thank you all again, and have a wonderful afternoon.